When news first broke that a mother in Duxbury allegedly murdered her 3 young children, 5-year-old Cora, 3-year-old Dawson, and 7-month-old Callan, the tragedy sparked a conversation about postpartum depression and psychosis. The mother, Lindsay Clancy, who's now facing murder charges, had reportedly been suffering from pregnancy-related mental health issues. And as part of her defense, her attorney has testified she had been taking as many as 13 medications prescribed to treat mood disorders, anxiety, and psychosis. Her attorney argues it was, quote, horrific over-medication, end quote, which he believes was responsible for homicidal and suicidal thoughts that led Lindsay Clancy to kill her children and to attempt to die by suicide. This alleged over-medication is something my next guest has seen for years. In Commonwealth magazine, retired First Justice of the Worcester Juvenile Court Carol Erskine wrote, "For decades in Massachusetts, the reckless indifference of prescribing psychiatrists and other providers has caused lasting and harmful consequences for so many adults and children who need help but cannot get services any other way." Carol Erskine is now an adjunct professor at Anna Maria College, and Lisa Cosgrove, a professor of counseling and school psychology in the College of Education and Human Development at UMass Boston. Welcome to both of you, and I want to make sure we set the table that medications do a lot of great work. They help a lot of people in need. There are a lot of doctors out there, nurse practitioners who are doing a great job medicating and helping people get the help they need for mental health and other ways via medications. But there's also some challenges around this. And Carol, in your piece, which really caught my eye, talk about your experience in the judicial system and what you saw and what raised your concern.
Yeah, I had many years in the judicial system as a judge for 20 years in the Worcester County Juvenile Court. And one of the main kinds of petitions that we would hear on child abuse and neglect cases were petitions by the Department of Children and Families to medicate children in their custody. So there are just countless children in state custody who are on medications, multiple medications. Under state law, the Department of Children and Families is not able to consent to treatment of antipsychotic medications for children, and therefore it requires judicial approval. So not only did I see those petitions, but I saw hundreds of children over the years on child requiring assistance cases who came into the court with parents and families who needed mental health help, who were on medication. And so one of the issues I always had was that it seemed like the default position to start children on medication as opposed to providing them with services and therapy before medicating them.
And what are some of the things that you saw, that you witnessed, that raised your concern, not only just the environment of how it was happening, but how it impacted the children?
Yeah, I mean, the side effects to these medications are just absolutely stunning, and they are severe in many cases. And so there were children who were on antipsychotic medication that had weight gain, so much weight gain, sometimes 30, 40, 50 pounds on certain medications, very young children, that caused them to have then problems with their sugar, pre-diabetes. We saw some young children with the uncommon but seen cases of increased levels of prolactin, which causes breast development and lactation. We saw children who had difficulty standing, walking, problems with gait, a condition also known as tardive dyskinesia, which causes movements, mouth movements and other movements, which were really, serious kinds of effects, and including some effects like tardive dyskinesia that even if the medication is stopped, those side effects can continue for a lifetime. So just a lot of harmful effects.
Lisa Cosgrove, in our family, my family at home, a number of folks have been on a number of medicines for mental health, and our experience has sometimes been, with great careful care from our providers, still a message of, well, we're not really sure if this is going to work. Let's try it for 3 months. Let's keep careful tabs on you. Here are the side effects. If it's not working, we'll change it. We've been privileged enough to have health insurance to be able to do that. We've been privileged enough that I've been able to go to appointments to supervise this. It's a lot of work for me. And I can't imagine what it must be like for children and parents who are in distress in a courtroom. What's your experience of what is being described by the judge?
So I think she brought up a really good point that there's this default position that we pivot automatically and consistently to a medicalized approach and to using psychotropic medication. And unfortunately, this leads to what I would refer to as irrational polypharmacy. That is when one agent is added and another agent is added because you're focusing on treating individual symptoms rather than looking at the patient holistically.
Carol, what power did you have? What power do we have? We're talking at length, it seems, every week for a while now, saying things like, if people need help, they should go get help. Oh, but there's a 6-month wait list. Oh, but these providers don't take insurance. You know, mental health providers routinely are able to not accept medical insurance to give treatment, although a podiatrist has to, a psychiatrist or a mental health provider doesn't have to. And sometimes that lands on the general practitioner to say, okay, here, try this. This is a Zoloft, which we know, or a Prozac, which has been around for a while, until you get to the next step. But the folks that you were seeing, the kids that you were seeing, they don't even have those options.
Right. And when I left in January, when I retired in January, there was an 8-month wait list in Worcester County to get services, and social workers were so frustrated by that. So again, you know, it's exactly what happens. They pivot to these medications, but and the other concern is that the medications that they start with are the most powerful medications in the continuum of pharmacological treatment. So rather than start with some of the milder non-antipsychotic medications or the psychotropics, they were moving directly to it. And the problem with it is, and as I said in the op-ed piece, is that they're using antipsychotic meds to treat behavioral problems, and they're not indicated for behavioral problems. And so kids are on these very powerful medications. You know, there's a lot of concerning information out there that I wonder sometimes if people are paying attention to. There was a study at Rutgers a few years ago in 2020 that looked at kids on the autism spectrum or who had pervasive developmental disorder. 300,000 of them were being treated with antipsychotic medication between the ages of 2 and 7. And so the whole notion that I tried to get across in the op-ed piece is that the diagnostic criteria keeps expanding and the age keeps expanding in the world of pharmacology. And it's having a detrimental effect on children. I just think there's a better way. From the bench, I could ask a lot of questions. I could say to the psychiatrist, let's try something different. Why are you starting with an antipsychotic? And if you're going to use this, I'm going to review it in 3 months. If there's no change, I'm going to ask you to medically remove the child from it. Some of these kids age out at the age of 18 out of the department. They're still on the medication. And then what do? They have no access to care.
You know, Lisa, the last thing I want someone to hear this is who have met with their medical professionals with their kids and they've had medication recommended. Certainly they want to investigate it and look at it, but they also want to keep an open mind and not dismiss it out of hand. But at the same time, you were shaking your head vigorously when I was describing how difficult it is to find a therapist or a specialty, someone who specializes in a mental health disorder, who accepts insurance. They all apologized to me. They're all sorry about it and described the challenges that the insurance companies are putting upon them. But again, does this not just push the inability to get providers to help with cognitive behavioral therapy or a specific treatment? It just pushes you right to medication. So what do we do?
Well, I think there's a couple things. One point that I'd like to raise is related to this is the fact that when fluoxetine Prozac came on the scene in the late 80s, we saw it as a magic bullet, and that magic bullet mentality is still with us. So we look to psychotropics as if they're analogous to antibiotics, and they're not. And another part of the problem is that there's a clear publication bias in the scientific literature. That That is, the efficacy is overstated and the harms are underreported. So a lot of prescribing providers are actually getting erroneous information.
Judge, what steps should someone, there's so many problems, as you kind of pointed out, there's so many challenges, and certainly the children that are in most need that don't have the supervision that they certainly have. Is there someone we should be contacting to demand greater care for the children who are either come before benches or are in our state's care?
Yeah, I mean, that's a great question. And the reason I say that is because it's really hard to know, for people to know who to get in touch with and what they're supposed to do. I mean, the state of Massachusetts was under federal oversight for 15 years until 2021 under the famous case called Rosie D., where a federal judge found that providing mental health services for the poorest children in Massachusetts was just not happening. And we were therefore under federal oversight. Not a lot has changed. You know, the Department of Mental Health, I do know that the Department of Mental Health is creating new programs, which is something that I'm looking forward to hearing about. Just heard about it recently at a judges conference. And so they're moving in that direction. But it's very difficult. The Department of Mental Health really in Massachusetts works to provide services for mostly adults, and there are not a lot of services there for children. I think it's unfortunate that people have to bring their child to a court to try to get help. That's one of the things that's really disturbing about this. When they can't get help and they can't get services, and the child is hospitalized and released from an emergency room, they send them to the court to try to get help and services. People shouldn't have to bring a child into a courtroom to get services for their child. So it's a difficult thing.
Lisa Cosgrove, I'm wondering what your feeling is. On one hand, we are certainly talking about mental health challenges in a way I don't think in my lifetime we ever had, and mental health services in terms of your workplace, making them available when you've had something traumatic happen, and discussions about the challenges for children. But at the same time, these obstacles are in place. How would you describe how you're looking at the mental health terrain right now? Are you cautiously optimistic? Are you optimistic? Are you worried? How would you describe yourself?
That's a great question. I think I would say cautiously optimistic. I see the younger nurse practitioners and psychiatrists being more open to critical thinking about psychotropic medication, about the research. So in that regard, I'm cautiously optimistic. I also see a little bit more of an emphasis, where there should be even more, on looking at the social determinants of mental health. That is, what are the upstream causes, and trying to address those and not just rely on a medicalized response.
Well, I thank both of you for your expertise and for allowing us to discuss this complicated topic. Folks, just do your homework, pay attention, and I appreciate you coming here. Thanks so much.
Thank you.
Thank you.